years of experience spanning multiple sectors, including biomedical science, clinical medicine, strategy, consulting, marketing, business development, executive management, and R&D management. With his domain expertise in medical devices, digital healthcare, healthcare IT, molecular biophysics, and medical imaging. He has authored 14 peer-reviewed scholarly papers, presented at conference proceedings, given keynote addresses and other speeches at scientific and business conferences and seminars worldwide, and co-invented 10 patent applications. He holds a few academic appointments and has had other previous executive roles in international companies in Korea, Singapore, and United States. Currently, he's a visiting professor at the Seoul-Bridge International School of Business and visiting teaching professor at Daegu Gyeongbok Institute of Science and Technology. He also holds executive and strategic positions in innovative companies in USA and Canada. He is also advisor for CREST Malaysia Digital Health Cluster. With his extensive experience in R&D, molecular biophysics, and biomedical science, he will unravel the issues and challenges of the COVID-19 vaccine. His talk is entitled COVID-19 Vaccines, Issues, Challenges, and Expectations. Please welcome Prof. Dr. Ogan Gurel.
Thank you very much. It's a pleasure to be participating in the Malaysian Military Medicine Conference. And I wanted to thank the organizers and the Defense Services Agency and affiliated organizations for hosting this wonderful program. I've had a chance to listen to the previous presentations and really enjoyed some of the insights presented there. So my talk will be about vaccines, but actually frame this more broadly because as Brigadier General Dr. Rosman bin Rahman mentioned, the new opportunities and new learnings that come out of this crisis. And I'd like to present my thoughts on that. As Lieutenant General Dr. Dato Amin mentioned about being at war, of course, many details related to that. And I wanted to talk about not just the battle, I view the vaccine as part of the battle, but a bigger war that's even beyond just COVID that has been exposed by this crisis. Dr. Nur Hisham, who is a fellow advisor and engaged with CREST Malaysia Digital Health Cluster. I've had the pleasure to work with him, and it's a great honor to share the stage with him. He mentioned about vaccines and quote unquote other measures. So I think that's very important. So I will frame this also more broadly. And finally, Dr. Ravindran, his very nice presentation about testing, talked about viral load being very important. And one of the key issues with vaccines will be about disease severity or preventing disease severity, as well as preventing transmission. Those are still open issues and they will affect the epidemiology and impact of this disease. And I'll touch upon some of those. So I thought this was, a good opportunity to further develop some of these very important insights that were shared in this conference before. So I will share my screen now. Okay, Bismillahirrahmanirrahim. COVID-19 vaccine issues, development, and expectations. I start out with a quote from Sir Francis Bacon, one of the founders of scientific method. Knowledge is power, but we unfortunately don't have complete knowledge. So I still think some knowledge is power, and that's going to be a theme of this presentation today. In other words, we don't know, as I mentioned, the vaccine effect on severity versus transmissibility. And there's so many open issues related to the testing as well, for example, with the mutation. So we don't have complete knowledge, and certainly we may never have complete knowledge, but we have to work with incomplete knowledge. But many of you being doctors, of course, are familiar with this paradigm, making patient decisions and sometimes life and death decisions in the face of incomplete knowledge. So with that caveat, let's begin. So I will be talking about four major areas: the virus enemy in terms of an overall framework, fighting the battle that we are in now, and where do the vaccine strategies fit into that? And then more broadly, winning the war. In other words, I'm going to present a very controversial thought in this presentation, that if we defeat this virus, we may have won the battle against the virus, but I think we will have lost a wider war. And so I'd like to position our thinking towards the wider war, as it were, and not just fighting this virus. So in terms of the virus enemy, what is a virus? As all of you know, it is genetic material contained within an organic particle that invades living cells and uses the host's and the metabolic machinery to produce new virus particles. So all of this is very clear, but it raises the important question, are viruses alive? And so if we classify viruses based on their outside versus their inside, the outside surface and the inside genetic, the outside surface defines the environmental stability, and that will have important implications for infection control, as well as, of course, the tissue specificity. And of course, there are two varieties of viruses, enveloped and non-enveloped. And then in terms of the inside, the genetic stability determines the genetic stability, the mutability, which we'll talk about, and also the proviral potential in the case of DNA viruses. So we have either DNA or RNA viruses. So all viruses fit into these categories. And as you can see, coronaviruses are in the enveloped RNA category. Now, why is this important? Because as many of you are doctors, you well know this, but I think in terms of public health, we have had, of course, experiences with eradicating diseases, smallpox being most notable of them, polio nearly so, or effectively so, and others. But they have unique characteristics. For example, smallpox is a DNA virus and it doesn't mutate so often. And so I think that a more, how should I say, nuanced understanding of viruses instead of just evil things out there in terms of the general public, I think is very important for our patients and for the general public as a whole. So the fact that these are envelope viruses and RNA viruses have important implications for vaccines, for infection control, and so forth. So if we talk more specifically about the SARS-CoV-2 virus, it has three parts clearly, from the inside to the outside: the nucleic acid, which is RNA, as I pointed out, the lipid membrane, and the spike protein. And the nucleic acid, being RNA as opposed to DNA, has a very high mutability with implications for immunity and vaccines, which Dr. Nur Hisham pointed out, as well as Dr. Ravindran, and I will expand further on that. And it's used, of course, for testing the reverse transcriptase PCR test, the rapid testing PCR test. And then you have the envelope virus, which has a lipid envelope, which essentially determines the environmental viability or vulnerability, depending on your perspective. So soap and alcohol clearly disrupt this membrane. And finally, the spike protein, which determines the target. It's blocked by antibodies and used in the testing that we'll also review very briefly here. So the big question is, are viruses alive? And no, and therefore there are only two ways to get rid of the virus. One is either to physically destroy it, or second is to clear it by the immune system. And obviously antibiotics cannot kill it. One cannot kill something that is not alive. And so clearance by the immune system is going to be a very fundamental biological strategy. And obviously vaccines play into that. Now, in terms of setting up a framework, Dr. Nur Hisham explained some of these concepts very well, but I wanted to outline a two-dimensional framework, if you will, about viruses in general, with on the vertical axis, the fatality rate, or case fatality rate, and on the horizontal axis, the transmissibility as numerically described by the R-naught or RT over time. Now, in general, and this has been very interesting as it's been playing out, there's an inverse relationship between transmissibility and fatality. In other words, more transmissible, such as measles, are typically less fatal, and less transmissible are typically more fatal, such as MERS, Ebola, and bird flu, and so forth. And the difficulty, of course, with the new coronavirus, SARS-CoV-2, is it's in this middle space. It's kind of the perfect pathogen, which has a fair bit of transmissibility, quite transmissible, and some of the new mutants are becoming more transmissible, and not insignificant fatality rate, of course, as we've all noted. Now, it's interesting about the evolution of viruses, and in fact, the evolution in general of pathogens, is they typically, over time, will evolve to be less fatal and more transmissible, because that's basically following the evolutionary paradigm of spreading its genetic material more widely. So generally, we're going to move down in this curve over time. There can be conditions, public health conditions, and this is extremely important to understand, where we could move up the curve and we can get more transmissible, more fatal versions, and so forth. So for example, we've talked about or heard about some variants that have become more transmissible, roughly speaking, going down this curve. And in some ways, ironically, that should be viewed as good news. Why do I say that? The virus is trying to be more transmissible because it's trying to accommodate the fact that it can't, under various social isolation or social distancing measures, cannot be transmitted so easily. So this mutation, aside from the intrinsic mutability of the virus, going towards more transmissible variants is suggesting that we are doing on the right track, as it were. Obviously, there's another factor in terms of trying to eliminate the virus so we don't get those mutations, but that's something I will talk about later. So this is a very important curve, and I'll talk about these two factors in turn. So first, I'll talk about the fatality rate, which I've colored in red here. And so as we know, the virus attacks type 2 pneumocytes in the lung, and specifically as distinct from the type 1 pneumocytes, which are 95% of the lung tissue, and influenza attacks those. It attacks those type 2 pneumocytes that are very critical for surfactant and gas exchange and so forth. And hence we have the hypoxia and respiratory distress by virtue of the ACE2 protein on their surface. Now, another very important concept, which will also relate to vaccines, is the concept of lower versus upper respiratory tract infection. So more upper respiratory tract infections are typically the common cold coronavirus. And about a third of the common cold, which is not that dangerous, which is why it's called a common cold, are in the upper respiratory tract and by coronavirus. And they tend to have high transmissibility and low fatality, infecting the nose, mouth, and trachea. On the other hand, more lower respiratory, such as SARS and MERS, have a low transmissibility, high fatality, again, following a bit that paradigm, and SARS-CoV-2 appears to be both, and this has important implications. The good news is because of this replication in the throat, a simple throat swab may be sufficient, maybe not necessarily the nasal swab, but it also has the bad news is that it spreads obviously through talking, and it's become fairly clear that it's airborne. So these are respiratory illnesses, and influenza is largely a respiratory infection. It never really has a blood-borne phase. Now, of course, people die of influenza. There's a cytokine storm, and you can have massive pneumonia and damage, in some ways more damage than in COVID, but you get a secondary pneumonia based on that. And so you can have a systemic extension and generalization of influenza, but typically you're not really infecting other cells. On the other hand, COVID, by virtue of binding to the angiotensin converting enzyme 2, which is involved not just in blood pressure, but also inflammatory processes, is also on other cells in the body. And that's, of course, with the spike protein, and the pathology is both cellular in terms of killing those cells, as well as directly and by the immune system, and also molecularly by reducing the ACE2 levels, which affect both the respiratory aspect by virtue of the cells, and by virtue of ACE2, some of the inflammation and fibrosis that we see, and hemodynamic abnormalities in the cardiovascular system more generally. So this is the respiratory part of the infection, but clearly it goes beyond the lungs, goes into cardiovascular system. There's the diarrheal disease, the eyes, the brain, nose in terms of loss of smell as being a key sense, liver, kidneys, and then also endothelial cells and the coagulation system. So this is clearly a systemic, can have a systemic phase as well. That's been confirmed by pathology. So this is extremely important for vaccines because In a sense, there are two immune responses that we're going to see shortly: IgG, which is a systemic antibody response, and IgA, which is a local or mucosal antibody response. And different vaccines and different approaches to vaccines will create different responses accordingly. So as Dr. Ravindran mentioned about the testing, I'll just review this very quickly. There are three ways to test for COVID-19. And again, we can focus on the nucleic acid or the spike protein. And as we do days since onset of symptoms, we can have RNA based tests, which is the PCR tests, which typically go 2 to 3 hours, and it's a swab test, as we mentioned. There are the antigen tests in the near term as well, and that would be a protein test by protein amino acid, typically a blood test that gives results in 10 minutes. And so these are diagnostic tests in terms of being infected with the virus, whereas the antibody tests, which are in several days after the symptoms, are serological tests, so the terminology is different, of having had the virus. So there's no one best test, and I think as Dr. Ravindran mentioned, there are many parameters, and he talked about predictive value, positive predictive value, and so forth. But there are other aspects to this. There's the timing of the test, which is extremely important, 2 to 3 hours versus 10 minutes, and it may not seem like a big deal, but I'll explain why that's very important. There's, of course, cost. There's where it is in the dynamics of the disease. So the selection of what type of test really varies along a number of dimensions. And it's not always clear whether we want a diagnostic test or a serological test. Well, it is clear, but there's no, I should say, test that fits all scenarios. And of course, there's also differences in accuracy, et cetera. One challenge with the antibody test problems are short-lasting immunity, different antibodies, limited accuracy, and so forth. Now, this is extremely important. We learned this in the Korea example, and I'll talk a little bit about the Korean approach to the epidemic in this regard, which we don't have a vaccine, by the way, here in Korea. But testing requires doing the follow-up. And in the United States, for example, there was a big politicization of the process, and the whole we are not testing or we are testing and not enough testing or too much testing. I mean, it was just getting out of control in that regard. But ironically, that was missing the point. Testing is meaningless without follow-up, and that follow-up being contact tracing, quarantine, isolation, and treatment. What Korea calls the 3 T's of testing, tracing, and treatment. If you don't have that, it doesn't matter if you have a test or not. And this is where the timing comes into play, as we'll talk about. If you act quickly on those test results, that's very important. Now, as Dr. Ravindran mentioned, the viral load is very important. If you do the PCR reaction, you have basically the number of cycles. And the number of cycles is a proxy for the viral load. If you need a few number of cycles, then you have a high viral load. If you have a high number of cycles that you need to get certain, you get a lower viral load. And studies have shown that there's been a correlation between mild and severe disease. And in other words, severe disease has more virus, more viral load, typically lower PCR cycles. And you remember the first doctors who died, the whistleblower in China, and the high susceptibility of healthcare workers, even if they were young, and he was just age 33. And of course, he's not the only case. Viral load may be an extremely important predictor of severe disease, whether you're young or old, and so measures to reduce that viral load are very important. So this is very interesting that Dr. Noor Hisham was talking about having more specialized approaches and not just blanket lockdowns and so forth, is that there's if you can minimize that viral load and still have the economic activities, maybe not in the same way, of course, that can go a long way, whereas a complete radical elimination of transmission. No one, I think, has ever died, we don't know, of exposure to a single virus particle. If we can modulate our approaches, social approaches to the viral load, as opposed to a kind of digital either or concept, I think that's very important and in the spirit of what Dr. Noor Hisham was talking about. So now we talk about fighting the battle. Now, as Dr. Noor Hisham mentioned, we talk about vaccines and other measures, but let's focus on the immune system, whose goal obviously is to destroy or eliminate foreign invaders. And then we can consider the immune system in its full spectrum as having a number of characteristics. There's the innate side and the adaptive side. There's natural versus artificial, and there's passive versus active. Now, active, natural adaptive immunity would be infection, whereas active artificial adaptive immunity would be vaccination. And that vaccination goal is what we are aiming at. Obviously, this is to increase or create a secondary immune response. So the primary immune response is low in terms of antibodies. And then the secondary immune response to re-challenge by that antigen, in this case, antigen A, is greater. And it should be noted, and this is very important for vaccine development, we'll talk about some of the nuances here, that not just antibodies, but also cell-mediated immunity has enhanced secondary response. And the cell-mediated immunity may be important for the longer term immunity. Now, a very important concept that's not often discussed in the realm of vaccines is the difference between mucosal versus systemic antibodies. And this talks about or references the difference between primarily respiratory illnesses, such as influenza or the common cold, the benign coronaviruses or adenoviruses as well are in that category, and the severe infections that go throughout the body, or infections that go throughout the body, but for whatever reason don't cause severe diseases. So in other words, we have localized mucosal infections, which would be the upper respiratory tract infections, versus systemic infections that are either lower respiratory tract or even effectively in the bloodstream. ACE2 is expressed on the endothelial cells, and virus particles are found in the body pathologically. So this leads to, there are two types of, again, there are many types, but just in terms of simplification, as many of you know, there are two types of immune. There's the mucosal immunity, which is mostly IgA, which is a dimer, and there's systemic antibodies, the more effective blood-borne antibodies through IgG. And so if we do an intramuscular or intradermal vaccination, we will get basically the IgG, which is lower respiratory tract and systemic antibodies. If we do intranasal vaccination, we will get this IgA. So you can imagine a situation that you vaccinate someone, they have good IgG and they prevent severe disease, but they're not, the IgG is a large molecule. It's not in the mucosa. You can imagine these patients still getting infected and still transmitting the disease. And while the question has not been answered, as you know, at least for the Pfizer vaccine and Moderna and some of the others, the effective endpoint in the clinical trials has been progression to severe disease. So you see the statistics reduce severe disease by 94%. The question about transmissibility, which obviously requires more people and more time, has not been definitively answered in the same way as progression to severe disease. So this is exactly what is happening. As far as I know, none of these vaccines are addressing IgA and directly addressing it, maybe doing it indirectly, the transmissibility issue. So I think very important, boosting the immune system is very important, getting enough sleep, updating vaccines in terms, other vaccines in terms of public health measures, healthy eating to improve the gut microbiome and to decrease inflammation, exercise, managing stress, and reasonable common sense supplements. And I think public health measures should include this kind of concept. And why do I say this in the context of vaccines? As I said, we want to win the battle, but there's also the war, and the war is more broad, as I will conclude in this presentation. And so some of these non-biological, if you will, non-therapeutic measures are going to be extremely important. So what about antivirals? And then, as I emphasized, unlike miracle antibiotics, penicillin, whatever, which kill bacteria, antivirals cannot kill viruses. One cannot kill that which is not alive. There are, many possibilities, but they basically interfere with different parts of the vaccine pathway, or I should say virus life cycle, from fusion, such as monoclonal antibodies, to endocytosis with chloroquine and hydroxychloroquine, to remdesivir that affects the proteolysis, translation, and RNA replication, to other agents that may inhibit packaging and virion release. So antivirals slow down the virus, allowing the immune system to clear it. And so we may also imagine, if some of the vaccines are incomplete, that we have some antiviral therapies to do that slowing down, because it's related to viral load. And so if we can reduce that viral load, as well as then we can reduce progression to severe disease. So this is just a brief overview of the vaccines. We have viral vectors. We have DNA vaccines. We have RNA vaccines. We have live attenuated vaccines and protein-based vaccines. I'll review these in a little bit more detail in a few moments, but I just wanted to give some summary high points of good news. Obviously, many vaccines now approved. Because this is an RNA virus, as I said at the beginning of this presentation, it's not going to be latent like hepatitis and herpes. So some of these have, very difficult vaccine targets. And unlike HIV, at least as far as we know, there have been some reports, but effectively SARS-CoV-2 does not destroy the immune system. And we still don't have an HIV vaccine. And that's probably one of the main reasons why. The bad news is, like the common cold, the antibodies might be short-term, in particular those varieties that are just in the upper respiratory tract, eliciting an IgA response and so forth. And the antibodies may vary in effectiveness. We also know, as I've highlighted, that because it's an RNA virus, it mutates. So it's like influenza, we may need vaccines every year that aim for the prevalent strains. And of course, on a sociological basis, anti-vax sentiment could be a barrier. Why is it that the antibodies may not offer as much protection? So if you remember, we talked about the SARS-CoV-2 being an envelope virus. So these envelope viruses have embedded in them, their envelope is basically the cell membrane of the previously infected cell. And embedded in that cell membrane are membrane proteins, such as the spike protein. And these, like eukaryotic animal cell cells, these proteins are typically glycated. So there's a fourth part to the virus, and that's the surface glycan sugars. And from the beginning, it was well understood that SARS-CoV-2 actually had significantly more glycan, more sugars on its surface than some of the other SARS varieties, and evading some of those antibodies, both natural, the person's antibodies, as well as, of course, those that could be induced by vaccines. So about 30% of patients failed to develop high titers of neutralizing antibodies, which those were early studies. So we have the 94% prevention of severe disease, but that may imply, well, there should be 70% prevention of severe disease, but these are not exactly measuring the same thing. You may have not really high neutralizing antibodies, but slightly lower levels of neutralizing antibodies, but it is enough, let's say, that you prevent the progression to severe disease. So it's not such a clear-cut issue. But that being said, unlike perhaps the rigid encapsulated viruses with a protein coat that have a very well-defined structure, and they don't have these glycan groups, these sugar coverings, might be difficult to produce these antibodies. So now let's shift to the green part, the transmissibility, the R-naught and the RT, as Professor Dr. Nur Hisham mentioned. It was initially thought the R-naught of 2 to 2.5, as he mentioned, that is now about 0.9, and that's the RT, or effective reproductive number, that changes over time as people get immunity via infection or vaccination. So the R may decrease over time. But in reality, the R is related to two things: the intrinsic factors, namely the nature of the virus, and the extrinsic factors, which is the nature of the population, the social measures. And I will talk about each of these in turn. Now, in terms of the intrinsic factors, how is it transmitted? How long is it viable? What is the incubation period? The R may change with mutation. In terms of the extrinsic factors, is defined by an equation beta times tau, the social distancing and protective measures, and the finding isolated and treating infectious people quickly. The mean infectious period, the R changes with the situation. So the 0.9 that we're talking about is related to the situation, all the measures that the Ministry of Health and Dr. Nur Hisham and colleagues have done. But as the mutation goes, as we talked about, evolutionary towards more transmissible, that's going to the opposite. So the nature of the virus is changing as well. So let's talk about these quickly in turn. So as we mentioned, the case in Malaysia, I actually took a screenshot from his presentation, Dr. Hisham's, and I put that here. So you see that the RT is 0.9 in Malaysia. So focusing on the intrinsic factors up here, we have the methods of transmission, direct, indirect, vector, and it turns out that SARS-CoV-2 has a very wide range of transmission mechanisms, person to person, droplet, airborne, fomites, fecal, oral. It doesn't say airborne here, but I meant to include that. So it's basically quite transmissible across a number of other mechanisms. So it has a fairly significant viability on surfaces, 3 hours in air, 4 hours on copper, 24 hours in cardboard. These are referring to fomites and droplets. And this lead to droplet precautions as well as contact precautions. And that's the science, if you will, the logic behind these precautions. So what about mutation? So as I mentioned, it's RNA, it can mutate it. And there have been many studies that have shown mutations that have involved replacement of the existing strains with more transmissible strains. And these are not surprising at all. I think this could be fully expected. Now, this is a scene from Wuhan in January 2020. And when I first saw this, I was very worried, not just because there were many people there. Obviously, that was a very difficult situation. But if you look at this hospital area, to avoid more pathogenic mutation, we should ensure individual, not cohort isolation. Now, let me explain this a little bit more. It's a public health issue, but it also relates to individual practice. So evolutionarily, viruses or any pathogen or any genetic material, if you will, wants to transmit itself widely. And so if that pathogen, that virus is killing the host, in other words, it has a high pathogenicity, high fatality, it will not transmit very readily because the host will be dying. It does not serve the virus any purpose in terms of its evolutionary sustainability to have a high fatality rate. So in general, these viruses will evolve, and that sounds like good news, to become less fatal. And that's one reason why we see some of these epidemics peter out over time. The bad news is that there is one circumstance in which viruses and pathogens more generally will evolve into more deadly strains. And that's when the transmission is easy. In other words, it's not any difficulty. There's no barrier to transmission. When does that happen? Right here. It's often thought that if we isolate patients, but they have the same disease, there's no problem. But if you isolate a virus that's rapidly mutating and you have them together and a lot of ability to cross-transmit, of course, those patients will not get more sick, perhaps. They may get more sick, but that's not the point. The point is you allow for the development of more pathogenic strains. There's another circumstance that was reported recently of an immunocompromised patient that had long-lasting infection for 6 months. And during that time, in that single patient, they had 20 or so more mutations that arose. And that was, of course, a case of continuous, easy transmission. So in terms of public health, we absolutely must do individual isolation. If we pack everyone together, even if they have the same illness, we may get a situation with a very fatal mutation. So indeed in Malaysia, they have been noted. Again, this is a screenshot of some of these strains that have replaced previous strains. And different variants have different transmissibility as seen by experiments, cell culture, human airway. This is the G614 strain outcompeted the D614 strain. And some of these antibodies cross-react, some of them don't. So there's no steady rule, if you will, to whether we will be able with the existing vaccines to counter all of these strains. The key thing is to try to minimize the opportunity for this mutation. So now let's move to the extrinsic factors very quickly, the primary mitigation strategies that we talked about. Dr. Nur Hashim mentioned about balancing the economy and so forth. Here in Korea, we have a fair bit of success. So I will describe how that works. 4 parts: we intervene fast, tested early and often, contact tracing, isolation, and surveillance, and engaging the public's health. And various measures were involved in that. But remember this equation that I mentioned, that the R is equal to the beta times the tau. So there was a sort of matrix approach, beta and tau, so different approaches addressing that equation. And the most important one is tau. Tau is the time. So time is extremely important. That's where if you have a 2 or 3 hour PCR test, which means that the person doesn't wait, they go home, and then maybe 24 hours later, it's all processed administratively, they get the result. If we're in an ideal situation, that time thing, because of the exponential nature of this growth, is very critical. So these are not new strategies. Obviously, Isaac Newton developed a calculus, which is not boring, in my opinion, by the way, isolating from the plague. And this is an old Spanish influenza document. So the same strategies are similar. So we're going to talk quickly about vaccines. And we have several types. We have classical subunit vaccines, which are basically the protein, and that's done through, that protein is taken up by antigen presenting cells. Some of the disadvantages are needs a booster strategy and short memory, and there are lots of examples of this in development. There's the inactivated virus, and this is also a very classic approach, was used in polio and the live attenuated approach in the virus-like particles. But the most recent versions, which are the most common that we've seen, AstraZeneca, J&J, Sputnik, and so forth, are recombinant viruses that basically take existing viruses and put, inactivate them and put the spike protein in there, so it produces that, mimics natural infection, maybe not exactly the same target, a strong memory, cannot revert to natural disease, and some of the other disadvantages is that if you have been infected by that, that artificial virus, if you will, the vector, that will lower the efficacy, and then you can potentially have recombination with other viruses to create some problems. And then the most recent one is these RNA vaccines, which are basically not viruses, they're just liposomes with RNA. And very important, they're easy to modify. So if we get a variant, we can create very quickly these vaccines just by changing the RNA. It doesn't clear any disease, but it tends to have a short immune memory. And again, this is not really affecting the disease process. It's not creating this sort of IgA response. It's the systemic thing. So it's no surprise that they affect the development of severe disease. I would not be surprised if these RNA viruses, vaccines, sophisticated they are, do not prevent transmissibility. So again, transmissibility versus fatality, we have mostly IgA and mostly IgG. I think these are open questions. So we might see eventually in the future, especially if we need to have multiple vaccinations, intranasal vaccination. So finally, I want to talk about winning the war. And I'll talk about 4 key issues: epidemic to endemic, chronic to acute, stochastic to deterministic, and treatment to prevention. So there is a bigger war going on, as Dr. Amin mentioned. So let's talk about some mega trends in medicine related to this. So there is the hope that, as I think I've mentioned, is not really possible of eradicating COVID-19. Now we have the example of smallpox, but I talked about some of the biological reasons as well as other reasons. So biologically, it's an RNA virus, so it mutates. The immunity is not as strong. It's the nature of the vaccine. Sociologically, we have the anti-vaxxers. So we defeated smallpox and polio during an era where we didn't have as much disinformation and sort of distrust of science, which is very tragic, but that's just the reality we live in. And likewise, people are against social distancing and so forth. And of course, pockets in terms of epidemiology, if we don't roll out the vaccine in a broad manner. So I think the consensus is, not just my opinion, that this will become an endemic disease. Eradication is very difficult. In fact, that's the exception rather than the rule. The other important trend that has been exposed by COVID-19 is the conversion of chronic diseases such as obesity, hypertension, cardiac disease, most notably, into acute conditions. I think this is a paradigm shift most people are obviously aware of, but the implications are not well appreciated. What do I mean to say? So for example, you have obese patients have a significantly higher chance of getting severe COVID than non-obese patients, all other things being equal. Obesity is not an acute condition. People do not die of obesity in 2 weeks, right? It's a long-term or chronic condition. But if you have COVID and you have obesity, that obesity can render your susceptibility to severe disease. So you do indeed die of obesity in 2 weeks. In other words, it converts chronic conditions into acute conditions. And why is this important? Because one of the reasons why we have so much chronic disease, 6 in 10 adults in the US have a chronic disease, 4 in 10 have 2 or more, and obviously the case in Malaysia as it ages, population and so forth, lifestyle aspects proceed, the same thing all around the world in many countries. These chronic diseases are treated in a not the same sort of intensity as something you would die 2 weeks from now. People don't address obesity as urgently as something like having a car accident and epidural hematoma. Now, obviously, I'm making extreme comparisons here, but COVID has changed the landscape, has converted chronic disease cases into effectively an acute situation. I forgot to mention diabetes. Then we are having another mega trend in medicine from the stochastic to the deterministic. What do I mean by this? Well, we have diabetes, we have obesity, and we have various statistics that someone may get some problems from that. But we don't really know what those are. But now with more digital healthcare and sensors, and this is the digital health cluster we're working with CREST and Dr. Noor Hisham, we can, and artificial intelligence, of course, we can convert some of this guesswork and probabilities into more deterministic information so that the chronic diseases can be managed more effectively. And that means we shift from treatment to prevention. So when someone has obesity, of course, we want to reduce that. When someone has diabetes, we reduce that. But typically the medical system is focused more on the acute manifestations. And if something is not dire, then we don't take care of it as urgently. But if you do have diabetes and there's COVID all around you, then that's a dire situation. Oops. So every challenge is an opportunity. My prediction is COVID-19 will evolve into an endemic disease. We know chronic conditions are risk factors, converting these chronic conditions into acute diseases. If we can truly prevent such chronic conditions, then we improve health broadly and also reduce the burden of COVID-19. That's the war that I'm referring to. How do we do that? Leverage the full potential of digital healthcare, comprehensive preventative care. COVID-19 effectively becomes like a common cold, and vaccine strategies can focus on regular vaccines for young and highly mobile against transmissibility, perhaps the nasal vaccine, and the high-risk individuals getting vaccines against the severe disease. So we have to think of a more comprehensive approach. And life will need to be different. This is extremely important. Everyone talks about going back to normal. But 200 years ago, even 100 years ago, most cities had open sewers. And of course, cholera and dysentery were endemic. Now, I'm not saying we go back to open sewers or we have anything like that, but we have implemented certain minimally taxed technologies and virtual technologies and other methods that minimize spread of this sort of disease. Maybe not as drastic as eliminating open sewers and not as drastic as lockdowns, but some of these measures should persist. Life is not the same as it was. Urban life or life in general is not the same as it was 200 years ago. So we will have some differences. And isolating, as Dr. Noor Hisham, selectively, what should be those things in terms of public health that we continue? I remember when I was in the New York City subway in the 1970s, I saw signs, no spitting. And people weren't really spitting that much. And of course, they don't really do that much now in New York City in the United States. But apparently back in the 30s and 40s and 20s and whatever, spitting was very common and tuberculosis was very common. So those signs about no spitting were related to obviously tuberculosis. And now we've had a cultural change and people just don't spit as much in open, in public, as a matter of culture. So things will be different. So that music that came up was from my book called Waves. Actually, it's not my music, but it's referenced in the book. And the character Thomas talks about war, not an ideal metaphor. Doctoring was very much like doing battle. Tenacity was required to defeat an enemy unrelentingly dedicated to killing their patient. To this end, he remembered listening for inspiration to the soundtrack from Barry Lyndon, The March of the British Grenadiers, a famous military march. In medical school, preparing for an exam, he would begin the day at dawn with a rousing turn of that storied music upon the record player. And then we can, just for a few moments, and then on that note, I will end. Thank you very much, and please take care. I can be reached on LinkedIn as well as via email, ogangurel@gmail.com.
Thank you so much, Prof. Gurel, for that highly engaging and informative talk. We are, again, very limited with time. So may I ask you just one or two questions?
Sure.
What is the current consensus, if any, on vaccination for those who are positive or have been infected with COVID?
In the past.
Now, do we know that, do we need to?
Well, I think there are two things.
When do we vaccinate them? Yeah.
Yeah, so there are two things. One is previous infection, and one is concurrent infection. So in general, whether it's COVID vaccine or not, and of course there may be some exceptions, but in general, as a matter of policy, we are not, it's not advisable to vaccinate people who have an active infection of any sort, right? So they ask if you have a fever and so forth. So let me interpret your question in terms of previous infection. Yeah. And in terms of previous infection, there's anecdotal evidence that people have more side effects and sort of a more vigorous response to the vaccine, which might be a good thing. I don't think there are any studies that show that people are contraindicated if they've had previous infection. And I think the strategy in the United States has been to vaccinate all healthcare workers, and many of them have actually had infection and documented and so forth. There are no exceptions. So I believe the feeling is to still vaccinate those people.
Is there a time period between the time they had infection and vaccination? There is.
Well, I cannot quote any formal recommendations, which I don't know are there, but just from kind of medical practice, if you will. If someone is not actively have an infection, in other words, they're afebrile and don't have other symptoms and so forth, and PCR negative, although that may not be a criteria. I don't think we have to test people PCR wise all the time, obviously, to get vaccine, but say they are negative as a result of having a fever and symptoms. If they're basically disease negative, I think that that's okay to give the vaccine, given the current situation. We may learn more in terms of those who have been previously infected, but I don't think the data is out. So I think the advisory, as I understand it, is basically to be agnostic with respect to prior disease status.
Okay. Second short question. With this many vaccines in the market now, I mean, many types of vaccines, is there any reason for preference for one vaccine over the other? Let's say for the RNA vaccine over the vector or the live attenuated, based on race, disease, or anything like that?
I don't think that there are any significant differences in terms of, well, let's look at the basic efficacy. My sense is that basic efficacy, focusing on severity, as I said, not on the transmissibility, which is an open question, and I still think is very important, and we need to have vaccines that address that. Again, maybe intranasally, but that's a future generation of vaccines. Okay. But in terms of primary efficacy, my sense is that they're all fairly similar. You know, the 80 to 90 to 95% prevention of severe disease. So the differences are related to two factors as I see it. One is practical factors. about cold chain supply, delivery, availability, and so forth, which are very important because if you can't vaccinate somebody because of practical limitations, it doesn't matter how efficacious it is, right? And the other one is relative to the new variants. And I think that that's still an open issue. There was a concern, if I understand correctly, AstraZeneca was not working against as well or against the South Africa variant. And so I think that as that develops, but I think it's really hard to predict. I mean, as Dr. Nur Hisham mentioned, you're already having 2 major variants coming up in the past few months. And so it's a moving target. So choosing the virus or the vaccine on the basis of what the variants, unless you really have a situation like in South Africa, where it's clearly that's what the situation is, I think is very hard to do. So I would be choosing those vaccines primarily on availability and practical concerns. And this is extremely important because I think because of the whole mutation thing, well, let's put it this way. With the testing, people came to the realization that the testing alone was not that important, was not the only solution. Testing plus the follow-up, which was the tracing and the quarantining, et cetera, and the treating was the key. Just testing is as we learn in medical school, the attending asks you, why did you do that test? And you say, well, I don't know. And they get angry at you. Well, they tell you, we learn from beginning of medical school, you only do a test if it changes your clinical management, right? So if nothing is happening as a result of the test, I mean, what's the point? So we learn hard lessons that testing plus expeditious testing, expeditious management, in other words, tracing. What I think is going to be important with vaccines is expeditiously delivering them quickly across a population. Why? Because if the vaccine is smoldering, right? I mean, the virus is smoldering and new variants are being developed that escape the vaccine or become more pathogenic or more transmissible, what's the point? You see? So vaccine is important, but a logistical effort, and we're talking, it's just like in war, you can have very powerful weapons, but if you can't bring the ammunition there, you lose, right? Logistics is very important. The quartermaster may not be the most glamorous general, but they're very important. So I think just like with the testing and expeditious tracing and treatment, the vaccine and expeditious rollout are going to be important. So my summary would be the practical aspects of that and getting that vaccine as quick as possible, whether as opposed to a 2% better in terms of efficacy, is going to be more important.
Roger. Right. Prof. Gurel, thank you so much for the answers.
Thank you.
For those questions, for those participants on Zoom, Prof. Gurel can still answer the questions if you wish, sir, through the questions that we pose there. So, but unfortunately, only participants who came in through Zoom can read the answers from the
not the YouTube.
You can do that. Okay. So
yeah.
Okay.
Well, I think we're late on time.
Huh?
I know Mr. Pack is waiting, so
he's waiting. Yes.
Well, thank you very much for the kind invitation. It was my honor and pleasure. Please take care. Thank you.
Thank you. It was our pleasure. So.